It will record today. I tested the audio. I did test recording this morning. I was a good boy, so let's see if this actually records. Last Thursday, I left you with a bit of a cliffhanger. I told you about a student who asked me, "Hey, Mr. Durst, how come semen doesn't taste sweet?" In response to me talking to the class about how semen has a bunch of fructose in it. And obviously, it was kind of an embarrassing question to ask in front of the class, but it was an honest question because semen has, let me pull it up here, all of that fructose in it. It has lots of fructose, or sugar in it. And that sugar provides a source of fuel to be used as ATP for the mitochondria, or for ATP production of the mitochondria in the mid-piece of the sperm. The reason semen doesn't taste sweet isn't because it doesn't have enough fructose in it. It's because of, next slide here, both the bulbourethral gland, let's back up 2 slides here. Here we go. Within this semen, we have secretions from the bulbourethral gland, and we also have secretions from the prostate gland. Those secretions, if we back up several slides to when I talked about those glands, contain alkaloid chemical compounds, or basic chemical compounds, that neutralize the acidic urine in the urethra, and that also neutralize the acidic environment of the vagina, or vaginal canal. We as human beings are pre-programmed to not like the taste of bitter compounds. Bitter compounds, or basic or alkaloid compounds, in most situations are alkaloid poisons in plants. And we have a very adverse reaction to it. And because of the basic chemical compounds in semen, most people associate semen with a very nasty flavor. It triggers their alkaloid poison reflex. Now, within semen, there's more than just sugar and basic chemical compounds. We also have proseminogen. Some of these words I struggle with. When we look at this protein, this is a precursor protein. It's not quite activated. Once it's activated, this protein is going to be put into its active form of seminogelin. Seminogelin, as its name implies, takes semen and makes it jelly-like, or gels semen. It's a protein in semen that makes it gel. And the consequence is that when semen first comes out, semen is very thick, it's very mucousy, it has a gel-like consistency. And from a reproductive perspective, this is super important. We want the semen to be really jelly-like so that it sticks to the cervix, the opening of the female's uterus, and so that it hangs out in there and entangles the sperm and maximizes the amount of sperm that enters into the female's reproductive tract. Our semen also is going to contain a signaling molecule, a category of molecule known as prostaglandins. In particular, these prostaglandins are going to cause the opening of the uterus, the cervix, to dilate slightly. So not only does semen stick to the cervix, it also causes the cervix to open up just a little bit to maximize the amount of sperm that enter the female's reproductive tract. Now, after about 20 or 30 minutes, we have a secondary chemical reaction take place. And this secondary chemical reaction is going to take the semen and make it become liquidy, become runny. Because ultimately, if the semen is going to remain gel-like and never become fluid, the sperm will remain entangled in it and not be able to move throughout the female's reproductive tract. In the past, I've had students ask me, how long does it take? How long does it take for the sperm to actually get into the reproductive tract? And if there's semen exposed to the cervix for about 5 minutes, you can pretty much assume that sperm have entered the female's reproductive tract. So when we look at sperm, in particular within the semen, we need 2 things for the sperm to become activated, for them to actually activate their flagella and start swimming. We need that elevated pH, alkaline pH, hence the bitter flavor of semen. And we also need the energy source. That's where the fructose comes in. So when we look at the prostate in particular, which makes up about 30% of the volume of the semen. The prostate is going to focus on buffering the acidic environment of the vagina. We'll go from a pH of about 3.5, which is about as acidic as the coffee in my cup, to a pH of about 7.5, which is about as acidic as milk, which is to say it's slightly alkaline. As the sperm are activated, they start to crawl or swim up the vagina and the uterus. I had mentioned the prostaglandins just a little bit ago. This is not a specific chemical compound. When we think of a prostaglandin, it's a broad category of chemical compounds. It's a signaling molecule based off of a fatty acid. And these particular prostaglandins in semen are known to cause mild contractions of the uterus, mild dilation of the uterus, in particular the cervix of the uterus. I remember when I was going to the birthing classes, when my wife and I were becoming parents with our first child, one of the tips that we were given was that if a woman is at risk of premature birth, she should avoid intercourse during the third trimester because the prostaglandins in the semen cause mild contractions of the uterus, mild dilation of the cervix, and increase the risk of her giving birth prematurely. Conversely, there's some old wives' tales that talk about how if you're past due or you're past your due date, you should have a lot of intercourse and have the semen hang out down there as much as possible so the prostaglandins can cause the dilation and hopefully initiate the birthing process. So let's talk about the male sexual response. When males are having sex, it's been organized into 4 broad categories. And this was done back in the 1950s, 1960s, so about 50, 60 years ago. And now that we have some organization to the male sexual response, we've been able to study it in more detail and come up with some therapies for individuals that have erectile dysfunction. When we think of sex or doing it, there's some technical names for it, such as coitus. And most of you probably know of coitus. It was made popular by the character Sheldon in, what's that show? I'm having a brain hiccup right now. Big Bang Theory, thank you. Yeah, because he uses that term all the time. But there's other terms like coition or copulation, which maybe you weren't familiar with. So let's talk about phase 1, the excitement phase. When we think of the male sexual response, I can't emphasize enough, it's simplistic. It's like pushing an on button. It's pretty well understood. So when we look at the excitement phase, this excitement phase can be triggered 2 different ways. There can be sexual thoughts that can trigger the excitement phase, or there can be physical touch, manual stimulation of the penis and the male's perineum. And once this happens, there's a dramatic increase in the male libido. Once we have the vasocongestion, or blood filling, blood engorging the erectile tissue, we are going to have the male's libido increased. There's some other things that occur during this excitement phase. We have myotonia. Some of the muscles associated with the penis become stiff or start to contract. This causes the penis to change the direction that it's pointing. And we're also going to have the bulbourethral glands secreting some fluid. The fluid, just to review again from the bulbourethral gland, is an alkaline fluid. And this bulbourethral gland makes about 5% of the volume of the semen, and this alkaline fluid serves primarily to neutralize the acid in the male's penile or spongy urethra. Now, when we think of the erection, I want you to focus primarily on the parasympathetic nervous system. There is some sympathetic activation for the erection process, but overwhelmingly the parasympathetic nervous system is responsible for the male erection. In particular, when we look at the chemical responsible, nitrous oxide, NO, that nitrous oxide is a neurotransmitter that causes vasodilation of the blood vessels that lead to the corpus spongiosum and the corpora cavernosum. And males must be excited. From a mechanical perspective, males have to be erect in order for the penis to penetrate the vaginal shaft and for semen to be delivered to the opening of the uterus. So the rhyme that works pretty well is that to get the penis pointy, you use the parasympathetic nervous system. P for pointy, P for parasympathetic. And then we have the plateau phase. This is the phase once the penis has penetrated the vaginal shaft. And we have repeated thrusting during this phase. It can sometimes, for some individuals, be really quick, just a few seconds. Sometimes, depending on the individual and their particular psychological state and how much excitement or stimulation they had leading up to this phase, it could be as long as a few minutes. The idea that this plateau phase can last for hours or last all night long is a misnomer. It doesn't last that long. If it lasted that long, the male would need to go to the doctor because having an erection for that amount of time could cause the blood to clot in the penis. That's why Viagra says that if the male experiences an erection for 3 hours, seek medical help immediately. You don't want to plateau phase to last hours. It's very unhealthy and can cause massive blood clotting and or death in the male. So we had excitement, we had plateau, now we have the orgasm or the climax phase. And for this phase, this is going to be associated with the discharge of semen, also known as ejaculation. This process can last as little as 3 seconds, as much as 15 seconds. It should be noted that during this phase, we have efferent stimulation, primarily powering the orgasm or climax phase. And this discharge of semen is going to be triggered by the sympathetic branch of the autonomic nervous system. So we had parasympathetic for pointy, we have sympathetic for shooting. Point and shoot, parasympathetic and sympathetic. So this emission, the release of the semen, is triggered by the the sympathetic nervous system. We're going to have peristalsis of the male's reproductive tract. There's going to be smooth muscle surrounding the urethra, and as that smooth muscle constricts and contracts, it forces the semen out of the penile opening into the female's reproductive tract. As we look at this process, it's worth emphasizing that the sympathetic reflex also constricts the internal urethral sphincter. In other words, it's physically not possible for a male to ejaculate and urinate at the same time. It's also worth emphasizing that orgasm and ejaculation are not necessarily the same thing. Now, in the male reproductive system, orgasm and ejaculation are kind of two sides of the same coin. One will typically immediately lead to the other. But when we look at the female reproductive system, orgasm and ejaculation can be very separate, distinct events from each other. So, after orgasm, after the ejaculation, we have the resolution phase. And during this resolution phase, this is when the male returns back to baseline. We go to the homeostatic baseline, heart rate goes down, blood pressure goes down, the amount of blood or vasodilation to the superficial blood vessels is reduced. In other words, the male cools off. When the male is in the middle of the sexual response, the blood that's being sent to the surface of the body increases surface body temperature. The penis also loses its erection. We have the vasodilation leading to the corpus spongiosum and the corpora cavernosa. And this causes the penis to become flaccid again. And this is a good thing because if we had stagnant blood in the penis for an extended period of time, that would trigger the intrinsic clotting cascade that we talked about at the beginning of the semester when we were covering the blood. Males typically have a refractory period. Think of this like the absolute refractory period of a neuron or a muscle cell. It's a period of time when the male is unable to achieve erection immediately following sex. It can be as short as 5 to 10 minutes if you're looking at a really healthy young male in his early 20s with a really high libido, or it can be several hours if you're looking at a male that's in his 50s or 60s and has reduced libido, reduced testosterone concentrations in his bloodstream. And then let's talk about erectile dysfunction. When we think of erectile dysfunction, this is usually going to be associated with the inability to achieve an erection or to maintain an erection long enough for orgasm and ejaculation to occur. And there's kind of a funny story behind this. Viagra stormed the market over a decade ago as the first drug to treat erectile dysfunction. Don't quote me on the pronunciation. I want to say the technical name is sildenafil for Viagra. And originally, when it was being made by Pfizer, during clinical trials, it was being marketed as a blood pressure medication, a medication to lower high blood pressures. And there were some interesting side effects noted in the male population during clinical trials. This drug that caused vasodilation and lowers blood pressure, in particular in males, caused a lot of vasodilation of the blood vessels that lead to the erectile tissue of the male and to the female, it's also worth adding. Consequently, these individuals had extended erections or extended engorgement of their erectile tissues. In particular, it does this by triggering nitric oxide secretion because it acts as a phosphodiesterase inhibitor. So let's talk about the normal sexual response. So the male's getting stimulated. As the male's being stimulated, that causes nitric oxide to be released. And then that nitric oxide goes through a cascade of chemical reactions. I do not want you to memorize these in-between steps. What the big take-home I want you to get is that nitric oxide ultimately causes vasodilation and erection. Now, this phosphodiesterase inhibitor is going to be responsible for down-regulating this cascade. In particular, it reduces the amount of cyclic guanine monophosphate that's present, that's triggering the vasodilation. It's also worth emphasizing that if somebody is taking medication for high blood pressure, that's contraindicated for a erectile dysfunction medication. In other words, if you're already taking medicine that lowers your blood pressure, you don't want to take more medicine that lowers your blood pressure. Taking a drug for erectile dysfunction while you're also taking a drug that treats your high blood pressure can cause a catastrophic drop in your blood pressure. So individuals that are taking medication for hypertension typically are not going to be allowed to take a drug for erectile dysfunction. And that leads us to our final review question for the male reproductive system. So this one's kind of beefy. It would have been easier if I'd gotten to it last Thursday. We have 5 hormones of the male reproductive tract. I'm going to give you an extra 30 seconds because it's kind of a tough one. Please match the hormone with its function. We have about 30 seconds left to make sure you get the question answered so you can receive your participation credit. We are down to 15 seconds. All right, so let's go over the answers. When we look at Mullerian inhibiting factor, that's using the old school name for the duct. When we think of the paramesonephric ducts, the old school name for paramesonephric duct is the Mullerian duct. And this Mullerian inhibiting factor that's released during embryonic development causes the tubes that form the female reproductive tract to degrade so that we can have the male reproductive tract prevail. When we look at testes determining factor, this is a chemical that's released early on in utero that causes the testes to develop. Once the testes develop, they release, oh, I can't see the bottom of my screen. Ooh, there were 7, my bad. So once the testes are made, the testes release a lot of testosterone. As we look at testosterone, testosterone does a lot of different things, such as stimulating male secondary sex response, and it also is going to downregulate GnRH, gonadotropic releasing hormone, secretion by the hypothalamus. When we look at GnRH that's released by the hypothalamus, it's going to travel to the anterior pituitary gland and cause the gonadotropins to be released. The 2 gonadotropins we really care about are follicle-stimulating hormone and luteinizing hormone. When we look at follicle-stimulating hormone, within the male reproductive tract, follicle-stimulating hormone stimulates spermatogenesis. Luteinizing hormone is going to stimulate the production of testosterone by Leydig cells, or the interstitial endocrine cells of the testes. When we look at inhibin, this is a hormone that's released by the nurse cells within the testes. It's going to downregulate follicle-stimulating hormone production by the anterior pituitary gland. In other words, the male has the ability to downregulate sperm production without downregulating testosterone production because of the inhibin only or selectively affecting follicle-stimulating hormone and not luteinizing hormone production by the anterior pituitary gland. So that was kind of beefy, a lot of hormones. We are all done with the male reproductive tract. Let's shift gears and focus on the female reproductive tract. As we look at the female reproductive tract, it was pretty complicated. So complicated that I had to break it up into 2 PowerPoints. We're going to cover half of it this week and the other half next week for the female reproductive tract. So as we look at the female reproductive system, I've said it before and I'll say it again, it's complicated. There's a reason why we have people that specialize in women's health, and you don't see doctors specializing in men's health, because from the male perspective, it's not that complicated. The reason the female reproductive tract is so much more complicated is because it has to do a lot more stuff. Not only is it going to be involved with the production and delivery of a gamete, it's also going to be involved with the receiving of a gamete. It has to receive the male gamete. It also needs to provide nutrition and an environment for the fetus to develop. It needs to be able to remove the child. The kid can't stay in the mother's belly forever. The kid needs to get out eventually. And then after the child is born, we are mammals, and mammals need to be able to give milk to the newborn children. So there's a whole bunch of extra functions associated with the female reproductive system. To regulate all of these extra functions, we have a much more complicated hormonal feedback system, which we'll be dedicating quite a bit of time to. So when we look at a child in utero, when they're at the fetal stage, they are indistinguishable physically from the gender perspective for most of the first trimester. You can have amniocentesis performed, where amniotic fluid is drawn out of the woman, and then you can test the amniotic fluid for the genetic genotype of that fetus, so you can determine gender early on in the first trimester if you so desire. Most people decide to wait until after 12 weeks and just perform an ultrasound. Now, as we look at the female reproductive tract, we're going to have the paramesonephric ducts, formerly known as the Mullerian ducts. And those Mullerian ducts are going to form into the uterine tube and the uterus and then the vagina. So it's going to form the female reproductive tract. Now we should really emphasize here, this is the default setting. In the absence of any altered signals, we will all develop as females. That's how we're programmed as males. So when we think of the development of the female reproductive tract, it's not because of the presence of estrogen. It's not because of the presence of the X chromosomes. Really, it's the absence of testes determining factor, and in particular, the absence of testosterone that causes this development. So let's focus on the ovaries. Instead of having testes develop from the gonads, we're going to have ovaries develop. The female ovary is going to be responsible for producing the female gamete, which is known as an egg or an ova, and many of the female sex hormones, in particular, the estrogens and the prostaglandins and the chorionic gonadotropins. As we look at the ovary, it is oblong, kind of a rounded almond shape, in many respects similar to the size and shape of the testes in the male's reproductive tract. And just like the testes in the male's reproductive tract, it's surrounded by a capsule called the tunica albuginea. Just like on the testes, we have that white coating around the ovary. And within the ovary, we have the middle layers and the outer layer. The outer layer is going to be referred to as the cortex of the ovary, and that middle region is the medulla of the ovary. And within the cortex of the ovary, right along the outer edge, is where the ova or the eggs develop. If the eggs or ova developed in the medulla of the ovary, they would be stuck inside of the ovary. So we want them to develop on the cortex so they can be ovulated or released to the rest of the female's reproductive tract. As we look at these eggs or ova, each one is going to be incubated in its own follicle. We typically will have one follicle per egg, or one incubation center per egg within the female's reproductive tract. And this process of physically releasing the egg from an ova is referred to as ovulation, when the follicle bursts and releases the secondary oocyte or ova. That is ovulation. After ovulation occurs, the egg is going to be received by the uterine tubes. Other names for the uterine tubes include oviduct or fallopian tube. Most people on the street and in common language will refer to it as the fallopian tube. The uterine tube is the name that started getting phased in about 5 or 6 years ago, is when I first saw that name appear in the textbooks, which is a good name because these are tubes that lead to the uterus. And as we look at these uterine tubes, formerly known as fallopian tubes, they're tubes that are about 10 centimeters long, so about the distance between the tip of my thumb and the tip of my pinky, so they're not terribly long. And the egg, or the ova, needs to travel through that uterine tube to get into the main body of the uterus. The egg itself doesn't have a flagella. It doesn't have a means of propulsion. So to move the egg through the uterine tube itself has a lot of cilia. Here's an electron micrograph of the uterine tube. We have ciliated cells that move the egg, and we also have secretory cells that release fluid that helps to carry the egg as this fluid flows through the uterine tube. And if we look at the uterine tube in more detail, we can break it up into regions. I like to think of the uterine tube as my arm. And we have fingers, we have a palm, and we have a long skinny area, and then it gets wider at the end. So when we look at the uterine tube, it has fimbriae, little fingers that extend outward. And those little fingers are analogous to the fingers of my hand. And they help to encapsulate or grab and direct the ova into the female's reproductive tract. And then we're going to have the infundibulum. So we go from the fimbriae to the infundibulum, which is a funnel, for lack of a better analogy. And that infundibulum will help to direct the ovum that's been picked up by the fimbriae towards the main part of the uterine tube. This main part of the uterine tube is referred to as the ampulla, which is present here in the uterine tube. And then towards the very end of the uterine tube, we have the isthmus. For those of you who like geography, an isthmus is a skinny projection of land towards an island. The closest isthmus I can think of is Canal Park in Duluth, Minnesota. I'm a former Bulldog, so I love Duluth. And when we look at the isthmus of the uterine tube, not only does it allow for the flow rate to increase, a narrow tube is going to have an increase in the amount of, or the velocity of the flow rate. This narrowing of the uterine tube means that the sperm which has entered the female's reproductive tract has a smaller target to hit. So as the sperm enters the female's reproductive tract, it needs to swim up through the uterus, find an isthmus, or opening of the uterine tube, and then get up to the egg to fertilize the egg. So this provides a much smaller target for the sperm and allows for a lot of positive selection, negative selection. Negatively will reduce the amount of sperm that are defective from getting to the egg, and that's a good thing. We want fully functional sperm because they're less likely to have chromosomal abnormalities associated with them. As we look at the uterus itself is not that large. Assuming the female's at a reproductive age and not pregnant, you can assume the uterus is about the size of your fist. So it's not an incredibly large organ when the woman is not pregnant. As we look at the uterus, its opening is the external os, and that marks the cervix of the uterus. This term cervix should not be foreign to you at this point. We talked about cervical vertebrae last semester, the vertebrae of the neck. And when we look at the root word of cervix, it means neck. So when we think of the cervix of the uterus, it's the neck of the uterus, or the skinny projection of the uterus that projects into the vaginal canal. From the cervix, we have the main body of the uterus. And this main body of the uterus is going to go to the opening of the uterine tubes. So from the opening of the uterine tubes to the internal os, or the beginning of the cervix, we have the B, the body. Superficial to the opening of the uterine tubes, we have a curved region that goes above the openings. This is the fundus of the uterus. For those of you who end up working in a birthing clinic, or maybe giving birth yourselves, it's not uncommon to have a fundus massage after giving birth, shortly post-birth, to help push out the afterbirth, or the excessive tissue and blood that can build up in the uterus as part of the birthing process. Now, when we look at the lumen of the uterus, this lumen of the uterus doesn't necessarily hang open that often. You could think of it as a potential space. So there's not going to be this hollow cavity inside of the woman's uterus. The lumen, though, if we were to open it up, is roughly triangular. It roughly angles down towards the internal os of the uterus. So ultimately, it helps to funnel the child out of the uterus to help with the birthing process. That internal os marks the beginning of the cervix. It's the interior opening of the uterus. And from the internal os to the external os, we have that cervix. Around the cervix, we have a lot of cervical glands. These cervical glands that are near the cervix are going to release a lot of mucus. And the primary function of this mucus is to plug the internal-external os. We want to plug the cervical canal so that microorganisms have a hard time entering the female's reproductive tract. Throughout the monthly cycle or the menstrual cycle, the consistency of this mucus plug changes from being an impenetrable barrier to being very thin and watery, to going back to being the impenetrable barrier, depending on how fertile the woman is during her monthly cycle. As we look at the muscular wall of the uterus itself, that muscular wall is going to be made up of a perimetrium, myometrium, and endometrium. When we think of peri, think of the outer perimeter. When we think of myo, think of the muscular middle. And then when we think of endo, think of the inside lining. The word metrium metri is a root word for uterus. So when we think of endometriosis, that's inflammation of the inner lining of the uterus, or the inflammation of the tissue associated with that inner lining. The myometrium, the muscular layer of the uterus, is made of smooth muscle. And because it's smooth muscle, the woman doesn't have voluntary control over the contractions of this muscular layer. Now, there's skeletal muscle associated with the abdominal wall, so when the woman is birthing, she can perform the Valsalva maneuver and help to push out the child. But the actual contractions of the uterus itself are autonomic. They aren't voluntarily controlled. When we look at this inside lining of the uterus, it's pretty special. It serves as a receptacle for the fertilized egg, for that zygote that develops into a blastocyst to anchor into this tissue and grow into a child. And because it serves such an important purpose, it's going to be the most complicated of the three layers. When we look at the endometrium, we have a simple columnar epithelium with lots of glands mixed in with it. There are two primary layers of the endometrium. We have the functional layer and the basal layer. The functional layer is the layer of the endometrium that's directly exposed to the opening or the lumen on the inside of the uterus. This is the part that the child or the zygote will implant in. It's also the part that's shed during the monthly menstrual cycle. And then we have the basal layer. This is the deepest part of the endometrium. It's the layer that's directly next to the endometrium. So in lab this week, when you're looking at your uterus microscope slides, to find the basal layer of the endometrium, look for the smooth muscle, and then the layer of tissue directly next to that smooth muscle is the basal layer of the endometrium. When you're trying to find the functional layer during lab, look for the layer of tissue directly next to the lumen of the uterus. That's the functional layer of the endometrium. As we move from the uterus, we're going to go to the vagina. The vagina itself is a potential space. It's a tube that's normally collapsed in on itself. A common misconception among young men is that the vagina is always open, kind of like a cardboard tube from a paper towel roll or a toilet paper roll. And that's an understandable misconception because all the diagrams in all the textbooks show it as a tube that's always propped open. But the reality of the matter is that it's a tube that's compressed on itself. There are no cartilage rings propping the vagina open like we have for the larynx propping the larynx open. When we look at the vagina, also known as the birth canal, it's about 8 to 10 centimeters long. This corresponds to being just a little bit shorter than the shaft of the penis. This allows for the penis to get into the vagina and typically get close to the cervix and deposit semen, but not necessarily be so long that the semen can't make it to the cervix or so short that there's pain from the cervix being impacted during intercourse. This vagina is going to allow for menstrual fluid to be discharged. It's also going to have a stratified squamous epithelium. The vagina itself is going to be designed to withstand some frictional forces. So if we look at that layer of tissue directly against the opening of the vagina, let me skip ahead a slide. Here we go. When we look at this tissue layer, we have that stratified squamous epithelium, which allows for the vagina to withstand a lot of frictional forces. It's worth emphasizing it is non-keratinized. The epidermis of our skin has keratin in its stratified squamous epithelium. This stratified squamous epithelium is more analogous with your pharynx or with the anal opening, in that it's a non-keratinized stratified squamous epithelium. The vagina itself doesn't have any glands or glandular secretions. So when we think of the moisture that builds up in the vagina, it's not necessarily from a specific secretion. It's more from the equivalent of vaginal sweat. We just have liquid leaking through the stratified squamous epithelium. And because it's a non-keratinized epithelium, it allows extra moisture to travel through it so that we have a lot of serous fluid that can build up within the vagina itself. As we look at the end of the vagina, The vagina itself extends slightly past the external os, or the cervix. And that little pocket back there is referred to as a fornices, or a fornix for the singular. When somebody is using a diaphragm for a method of birth control, the ridge, the ring-like ridge of that diaphragm is oftentimes going to be tucked into the fornices to help wrap it around the external os to prevent the passage of sperm into the female's reproductive tract. The vagina also has friction ridges. And these friction ridges, or rugae of the vagina, serve twofold. They help to stimulate the gland's penis during penetration to cause the male to ejaculate, and they also have been associated with female excitation, or stimulating the female during reproduction. There has been some talk of these frictional ridges being the physical manifestation of the G-spot within the female's reproductive tract, although it's highly variable from woman to woman, which is one of the reasons why there's been no specific, how could I say this? Nobody knows for sure, because it's so variable from female to female, what specifically stimulates them. Ladies are just more complicated than men. When we look at the vagina, there is in individuals who have not had intercourse or lots of physical activity, oftentimes there'll be a fold of mucosal tissue within the vagina. This fold or flap of tissue is referred to as the hymen. In most situations, the hymen has a hole in the center of it, which allows for the passage of menstrual fluid, but the hymen itself doesn't have an opening that's large enough for the passage of a penis, or the glans penis, to move past it, which is why this flap of tissue is traditionally associated with virginity, because if a penis has penetrated the vagina, it usually will have torn this flap of tissue. This first time that an individual will have sex, the first time a female has sex, this tearing of the hymen is oftentimes very painful and associated with a small amount of blood being discharged. As we look at the vaginal epithelium that lines the uterus, when individuals are prepubescent, when females are not yet fertile, we have simple cuboidal epithelium. And as that young lady or that young girl becomes a young woman, there's a morphing of the tissue that lines her vagina. And this process of morphing is referred to as metaplasia. That simple cuboidal epithelium becomes the stratified squamous epithelium. So one way you can look at the fertility of a female is to look at the tissue that lines the vagina. If it's a simple cuboidal epithelium, that is a prepubescent female. If it's a stratified squamous epithelium, it's a postpubescent female. It's also worth emphasizing that within the vagina, there's a lot of bacteria. And that bacteria in particular are going to break down the animal complex carb, glycogen. The vagina is a low oxygen environment. We don't have a lot of air supply to the vagina. And because there's bacteria in that low oxygen environment, the bacteria is going to go through anaerobic respiration or fermentation and produce a lot of lactic acid, which acidifies the vagina. And this acidic environment of the vagina is going to inhibit the growth of many common pathogens. Sometimes individuals or females will get into the habit or get the notion that they need to regularly flush out the vagina or douche frequently, and there's some risk associated with that. Frequent douching will raise the pH of the vagina to more of a neutral pH and potentially allow for pathogenic microorganisms to reproduce and grow within the vagina, the most common of which would be a yeast infection. As we look at the perineum of the female's reproductive tract, we have the external genitalia. The collective term for the external genitalia is the vulva, also known as the pudendum. It is not the vagina. You don't actually see the vagina from the external view. And as we look at the external genitalia of the female, we'll start from superior and work our way inferior and then posterior. So, in front, we have the mons pubis. Mons is a root word that means mountain. It literally means, if you look at the words, the pubic mountain. And the mons pubis in the female reproductive tract is a thick layer of fat directly over the pubic symphysis. The mons pubis is also going to have some pubic hair associated with it as well. It serves the function of cushioning the pubic symphysis. During intercourse, there's a lot of thrusting and penetration, and if the mons pubis isn't there or well developed, it can cause pain or bruising of the female around the pubic symphysis. We also have the folds of tissue known as the labia. We have the labia majora. Excuse me. Let's try that again. We have the labia majora and the labia minora. Labia is a root word that means lip. And as we look at these folds of tissue structurally are similar to the lips around the oral cavity in that they're flaps of soft tissue. The majora are the large flaps of tissue. The minora are the smaller flaps of tissue. As we look at the labia majora, they are going to be lateral, and they're going to contain a stratified squamous epithelium and also contain pubic hair. When we look at the labia minora, they are medial, closer to the opening of the vagina, and these folds are going to be hairless. There will be no pubic hair in the labia minora. They are not going to have the stratified squamous epithelium. Instead, they're going to have a mucous membrane that's much more likely to be sensitive or sensitized. And let me clear the screen again, the labia minora, the smaller lips, are going to converge and form a flap of tissue known as the pupus. This is analogous to the pupus of the male's reproductive tract. So when we think of an uncircumcised male, the uncircumcised male is a gentleman who will have a flap of skin covering the glands, penis. That flap of skin covers the most sensitive part of the male's reproductive tract. In the female reproductive tract, the pupus is a flap of skin that covers the most sensitive part of the female's reproductive tract, the clitoris. Here's a fun fact for you. The number of sensory nerve endings present in the glans penis, or the head of the penis, are equal to the number of sensory nerve endings present in the clitoris. So you have two structures with an equal number of sensory receptors, but one is much, much, much smaller than the other one. In other words, in terms of human anatomy, the clitoris has the highest density of sensory receptors in males or females. It's the single most sensitive spot in either gender. As we look at the clitoris, it's worth emphasizing that it's analogous to the glans penis and the shaft of the penis. And because it's analogous to those structures, it's going to contain erectile tissue. It is possible for females to get erections. It's a very normal part of the female sexual response. So when the female is sexually stimulated, or if the female has taken Viagra, this female will have her erectile tissue become engorged with blood. As the clitoris becomes engorged, it is going to shift through the female's reproductive tract and change position, which allows for it to be more easily stimulated during the plateau phase of the male sexual response. As we look at the vestibular bulbs are parts of the erectile tissue that are deep to the labia majora. So those vestibular bulbs, I know my screen is cut off here, are located within the labia majora and cause engorgement of the labia majora. It's also worth emphasizing that there's also erectile tissue within the labia minora as well. So when the female is becoming sexually aroused, or if she has taken a drug that causes her to have elevated nitric oxide levels, there will be the engorgement of those tissues. So let's pause for a moment and have a review question. How many openings lead into the uterus from the outside of the uterus? So we have a structural question for you here. Flip back a couple slides. Think of the uterus. How many openings lead into the inside from the outside of the uterus? We're down to about 15 seconds. Make sure you get your answers in. 5, 4, 3, 2, 1. Oh, I guess we have a little time left. Okay, now we're done. So, as we look at this, we have a pretty solid understanding here. We have 3 openings from the outside of the uterus that lead to the inside of the uterus. So let's back up several slides here. Wait for it. Did I just crash the computer? No, I didn't. Okay, good. So let's look at this picture of the uterus. How many openings lead to the uterus from the outside of the uterus? Here's the uterus itself. We have 1 uterine tube, 2 uterine tubes, and then an external os. 3 openings lead to the inside of the uterus from the outside of the uterus. Oh, wait for it, wait for it. Apparently I'm inept right now. So let's talk about the breasts or the mammary gland. As we look at the mammary gland, both males and females have mammary glands. The reason females have larger breasts than males is because the females have been exposed to hormones that have promoted the development of the mammary tissue or of the breast tissue. So as we look at the breast, it's just a mound of tissue that overlies the pectoralis major. This mound of tissue is going to involve a lot of adipose, a lot of areolar tissue, and depending on the hormones the individual has been exposed to, varying amounts of glandular tissue, varying amounts of mammary glands. And these mammary glands are going to shift throughout the female's reproductive cycle. Not only does the mammary gland tissue develop a little bit during the monthly cycle and then shrink a little bit during the monthly cycle, during pregnancy, the mammary gland enlarges dramatically, and then when the woman stops lactating, the mammary gland reverts back to its pre-pregnancy size. So as we look at the breast, here's a cross-sectional diagram from your text. We have the main body of the breast. You can think of it as a cone. And it's going to, at the tip of the cone, have the nipple. The breast also has an axillary tail. Axillary refers to the axillary region of the body or the armpit. The breast actually wraps around the chest and goes into the armpits. In particular, if we're looking at a female with well-developed breast tissue, the axillary tail can be quite significant. This is important if somebody has reconstructive surgery, or maybe they had a radical mastectomy and they're putting an insert into their bra. A good insert will include an axillary tail region to simulate the normal shape and appearance of a breast. As we look at the very tip of the breast, it is called the nipple. A common misconception among individuals who haven't been parents yet is that the nipple has just one opening at the very tip. The nipple does not have one opening. It has multiple openings that come from the multiple lactiferous ducts that all converge at the nipple. And as we're looking at the nipple, it's going to be surrounded by a darkened region, a very sensitive tissue known as the areola. The areola is a darkened region around the nipple, which I'm circling right here. So there's the areola. And that areola is darkened because it has lots of blood vessels very close to the surface of the skin. And this is a very important tissue because stimulation of the areola is going to be associated with certain hormones being released within the female. And these hormones are responsible for both letdown of milk and also for sexual response. The bonding or love hormones are going to be released as well. It's worth emphasizing that during the nursing process, a lot of bonding of the mother to the child occurs when there's stimulation of the areola, triggering the release of oxytocin that helps to solidify the maternal bond to that child. Now, as we look at the areola itself, here's a photo I pulled from the internet. Oftentimes will be bumps in the areola. Those bumps are referred to as areolar glands, and that's a pretty good name. You know, the glands of the areola are areolar glands. And that was the name I was familiar with, but I remember very specifically talking with my wife and the lactation consultant after she gave birth the first time. The lactation consultant came in, and she used this term, Montgomery glands. And when you work with individuals that are in birthing wards, this is by far the most common term that you'll hear. All the nurses were using that term. So know that Montgomery glands is an old school name for areolar glands. It's not in your textbook, but it's still pretty commonly used. It's been passed on from one midwife to another midwife during the internship process. These areolar or Montgomery glands serve a very important purpose. They secrete a very thick, viscous compound with a high lipid content. And the high lipid content of this compound is going to moisturize the areola and the nipple and reduce chafing and cracking during the breastfeeding process. Depending on how strong the child's latch is or how aggressively the child sucks, some women experience a lot of pain during the breastfeeding process, or if you have a more of a gentle or weaker child, sometimes there's less pain associated with the breastfeeding process. Individuals that either don't have enough Montgomery glands or areolar glands or have a very aggressive breastfeeder oftentimes will supplement with lanolin or other lipid-rich creams to help reduce the amount of chafing and cracking that can occur. It's also worth emphasizing that there's a lot of smooth muscle within the areola and the nipple. This smooth muscle will involuntarily contract during the sexual arousal process of the female, causing the nipple to become erect and allowing for more direct manual stimulation of the nipple. During this process of manually stimulating the nipple and areola, there's a release of oxytocin. And this is a very good margin note to write down. And this oxytocin that's released while manually stimulating the nipple is responsible for the bonding process. So if we have a child that's breastfeeding with mom, it helps the mom to form deep emotional bonds with the child. If it's during sexual intercourse, it helps the woman to form deep emotional bonds with her sexual partner. And oxytocin does more than just stimulate the formation of deep emotional bonds. It also stimulates contractions of the uterus. So if you're working with a patient that's at risk of premature birth or premature labor, another thing that's contraindicated or that they're advised to avoid is stimulation of the nipple during the third trimester. Here's a cadaver breast with a mid-sagittal slice through it. And as we look at the cadaver breast, one thing to emphasize is that it is mostly adipose tissue. And the biggest factor that determines the size of the breast isn't the size of the mammary gland, it's the amount of adipose tissue which is deposited within the breast. To help hold the breast up, there are suspensory ligaments. And you can see those suspensory ligaments as little tiny white lines within this adipose tissue. Those suspensory ligaments will anchor to the fascia of the pectoralis major and eventually work their way to the epidermis of the breast tissue. And they help to support and hold the breast up. These suspensory ligaments are made of a dense, regular connective tissue, so the same kind of tissue that makes up tendons and ligaments, and are prone to stretching over time. So when we look at individuals that have a lot of adipose tissue in their breast, that adipose tissue is going to generate more gravitational force, tug on the suspensory ligaments more, and over the lifetime of that female, the suspensory ligaments stretch out more. When you're working with a geriatric female, it's not uncommon to have breasts hanging down by the belly button or by the navel, or every once in a while, having the breast hang down below the belt line. And this is one of the things that needs to be avoided when you're helping a geriatric female with bed transfers or toilet transfers. This is a notable health concern. The suspensory ligaments are like other connective tissues in the body as well, in that if you don't stretch them out repeatedly or minimize the amount of stretching, they will maintain their recoil or the elasticity. So individuals that are not well endowed when they're in their 20s, think of a female with an A cup They don't have as much sagging or stretching of the suspensory ligaments in their geriatric or golden years. Also, individuals that wear more support have less stretching or sagging. We've all been there. We've all looked at those National Geographic magazines of individuals in the jungle who have never worn a bra. And there's extra sagging or extra stretching of the suspensory ligaments associated with the lack of support they've had throughout their lifetimes. As we look at the mammary glands within the breast, these mammary glands are going to spread throughout the adipose tissue. They are interspersed throughout the adipose tissue. When a woman is not lactating, the female's mammary gland is going to be about the size of a walnut. So they're quite small. And then when the woman is exposed to the hormones that stimulate lactation, primarily prolactin, there's going to be a development of the mammary tissue as they swell and engorge with milk. The mammary gland is made up of, depending on the individual, 15 to 20 lobes. These 15 to 20 lobes are going to have an acini at the end, or a sac of cells that produces the milk at each end. And those acini will drain into lactiferous ducts. Those lactiferous ducts will all converge at the nipple. So when we look at the female's nipple, when she's lactating, there will be 15 to 20 small openings in each nipple that will each drain milk individually. It's also worth emphasizing the acini themselves, so these sacs that contain the milk within the mammary gland, are surrounded by a myoepithelial cell. This root word myo is one we've talked about frequently. It's a root word for muscle. So the mammary glands themselves are surrounded by muscular tissue. This is a smooth muscle tissue that is going to constrict when the woman is letting down milk. And there's several things that can trigger the constriction of these myoepithelial cells. Prolactin does not. A lot of students make this mistake. Prolactin is a hormone which does not trigger the letdown of milk. It triggers the production of milk. But after the woman makes the milk, the woman needs to get the milk out of her body. And that's going to be triggered by a hormone called oxytocin, that hormone that's associated with the contraction of smooth muscles, both the smooth muscle of the uterus and the smooth muscle of the breast. There's also going to be some autonomic nervous system associated with this as well. Some women that have formed a very strong bond with their child have been trained to constrict, and this is at a very subconscious level, will associate the crying of their child, and only their child, not anybody else's kiddo. They'll associate the sound of just their kid crying with breastfeeding, and when they hear that noise, they start to let down milk in response to the sound of their kid crying, kind of like the bell in Pavlovian dogs. Most women, though, don't experience that during the breastfeeding process. And instead, it's the manual stimulation of the areola by the child latching on and suckling that triggers the letdown of milk. Oh boy, puberty. This is when it gets complicated. We have about 4 minutes left of class, so I'll cover a couple slides, and we'll pick up on puberty for the female on Thursday of this week. So for females, puberty starts when they're a teenager, when they're the ages of 8 to 10. And this is not necessarily going to be menarche or the menstrual cycle. So this puberty state begins a couple years before the young lady has her first menstrual cycle. So we have the development of the uterus, we have the development of the mammary tissues, the breasts start to grow when the young lady is at the ages of 8 to 10. Puberty is triggered in a young lady by gonadotropin-releasing hormone being released from the hypothalamus. That gonadotropin-releasing hormone is going to travel to the anterior pituitary gland and trigger the release of follicle-stimulating and luteinizing hormone within the female's reproductive tract. For females, since they have an ovary instead of a testes, there's follicle-stimulating and luteinizing hormone will do some different things. In particular, follicle-stimulating hormone is going to trigger the development of an ovarian follicle. This ovarian follicle, as it develops, will then release additional sex hormones, in particular estrogen, progesterone, and inhibin, and a very, very tiny amount of androgens. When we think of androgens, think of male sex hormones. So when we look at a young woman who's at the peak of her fertility in her early 20s, the concentration of androgens in her body is as high as it will be in her lifetime. And just like with males in their early 20s, females in their early 20s will have the maximum amount of skeletal muscle mass that they'll experience over the course of their entire life cycle. To give you some perspective, the levels of androgens in a female in her early 20s are equivalent or about equal to the concentration of a male in his mid-80s. When we think of the estrogens that are being produced by the female's ovary, the estrogen is a term that commonly is used to refer to just one hormone, but it's really an umbrella term that refers to 3 different hormones that all have a similar function and structural formula. Of those 3 estrogens, estradiol is the single most important variation of the 3 estrogens. We also have estriol and estrone, which to a lesser degree are significant. And we'll stop with this slide, and we'll pick up on Thursday.